Small incision cataract surgery. The first step is to pass the superior rectus bridle suture through whole of the superior rectus muscle after grasping the muscle with the superior rectus holding forceps. Coming over to conjunctival peritomy, grasp the conjunctiva with the help of Lim's forceps. Make a small nick in the conjunctiva and the subconjunctival tissue and dissect along this plane. Make an adequate size conjunctival flap, but remember, do not over dissect as it could lead to difficulty in visualization of further steps due to excessive bleeding. Cauterize the scleral bleeders only. Avoid forceful rubbing of the cautery tips to sclera as it could lead to scleral thinning and astigmatism. Incision should always be marked for the beginners. And remember, if you are giving blue menthol technique, do not forget to give back cuts of 1 to 2 mm size. Incision depth should ideally be 50 to 75% depth of the sclera. Here we are constructing the tunnel with the help of crescent knife. We enter and then we make the side pockets. The side port construction with the MVR knife is being done over here. Here we are staining the interior capsule with the trypan blue dye. We are constructing another side port which is comparatively larger in size so as to help in insertion of AC maintainer, which will help us to preserve the fluidics of anterior chamber. Capsulotny is another very important step in SICS. Here a CCC is being attempted, though there is difficulty in initiation of the flap. So it is very common for the beginners to have difficulty in initiation of flaps. So gently try to complete the CCC. If you still face difficulty, try holding the flap with the help of the capsulorhexis forceps and complete the rhexis as seen here. This is another clip showing CCC in a soft nucleus. Here, the CCC is being done in the retro-illumination, which is a preferred choice of illumination for CCC. So always remember to perform CCC in retro-illumination. Here we can see CCC is almost complete. Coming over to entry into anterior chamber via keratome via dimple down technique. Then extend along whole length of the tunnel. Make adequate size tunnel entry. Nucleus management. Hydrodissection is being done over here gently as seen here now. So after hydrodissection we are trying to prolapse the nucleus into AC. Since the nucleus is large and tunnel is comparatively small, delivery of this nucleus was done slowly through the vectus. After this we are showing another clip in which hydrodissection is being performed in a soft nucleus, and slowly we are trying to prolapse the nucleus into anterior chamber. So remember, if there is extension in rhexis, perform gently hydrodissection. And this is the nucleus delivery via blue menthol technique. Pressing on the lips of tunnel, the nucleus comes out. Cortical matter aspiration should be done under retroillumination from periphery towards the center. Engage the cortical matter and suck it up. Iod placement here is being done under anterior chamber maintainer. A rigid IOL is being inserted into the bag. Leading haptic has gone inside. Trailing haptic is still outside. Oh, it's almost out again. The leading haptic. So after putting the leading haptic in the back, we are trying to dial the IOL. And after placement of the IOL in the bag as seen over here, we are hydrating the side ports. The last step is to cauterize the conjunctival flap we had made. Thank you for watching the